Good evening. Welcome to the Honors Colloquium. We have something a little unusual tonight, and I think you'll enjoy it. My name is Mary Cloud. I'm from the College of Nursing and one of the coordinators of this year's Colloquium. Tonight we present Damaged Care, the musical comedy about healthcare in America, written and performed by Greg LaGana and Barry Levy. Greg and Barry first collaborated when they were classmates at Cornell Medical College, where they wrote 3 musical comedies satirizing their professors and their life as medical students. For their 25th medical school reunion in 1996, they wrote and performed Damaged Care. They have performed the show at many venues in 28 states and in Canada since then, including off-Broadway in New York. Tonight is their 125th performance. They are accompanied by the musical director, Brad Ross. Their performance will be followed by a 30-minute question and answer period using our usual format, and they'll also let you know that there'll be DVDs for sale afterwards in the lobby. Thank you very much, and welcome.
Hello, and thank you for calling the voice recognition hotline of Community Healthcare Systems Incorporated, a wholly owned subsidiary of the R.J. Reynolds Tobacco Company. Please enter your 43-digit identification number now. If you are calling about a hospital bill, please enter or say 1 now. If you are calling about pre-certification, recertification, or decertification, please enter or say 2 now. If this is a life-threatening emergency, please enter or say life-threatening emergency. I'm sorry, I did not understand that. Please hold for the next available operator.
Ladies and gentlemen, we now present for your entertainment and continuing education the musical comedy about healthcare in America. Please welcome Damaged Care!
Damaged care. There are questions that we pose. Damaged care. Is there someone here who knows if healthcare is a privilege or a right?
That's a question that we'll answer here tonight.
Damaged care. Can you give your patients love? Can you care when you're managed from above?
Can you still be a good doctor when you have to watch the clock?
And the only thing that's valued is the value of the stock.
Do you argue?
Do you protest? Do you dare? Damaged care. Managed care.
What is managed is the cost.
Managed care. Have our values all been lost? To keep our patients, we've had to enroll in programs under bankers' full control. Damaged care. Have you ever wondered why? Do you know
if you have the right to die?
Do you know whether Obamacare will help the uninsured?
Do you know if the whole system will collapse
before it's cured? Have you thought about these problems? Do you dare? Damaged care. Well, thank you.
So wonderful being here at the University of Rhode Island. Everybody's looking so great.
I don't know, everybody's looking kind of stressed out to me.
Greg and I have some songs for you this evening about the wonders of healthcare in 2012.
I don't know about you guys, but I'm pretty scared about healthcare in 2012.
We'll look at the wonderful partnerships between business and medicine.
Sellouts.
We'll cruise the information superhighway.
It's time to learn all that stuff.
We'll celebrate the growth of for-profit healthcare.
We'll mourn the collapse of public hospitals and community health centers.
We'll look at cost containment.
Cutbacks in essential health services.
We'll examine how in the U.S. economy today, healthcare is accounting for 17% of employed people.
Yeah, and 17% of unemployed people.
And we'll reminisce about the good old days when we were both medical students down in New York.
Okay, I'll give you that one. The good old days. For our patients, we were there. We learned caring, not just care. We learned all about the human touch. We worked long into the night, cause our future seemed so bright. We were doing what we loved so much.
More than blackboards filled with chalk, our professors walked the talk. We were moved to see ideas could last.
So compassionate and wise, they saw something in our eyes. Unbeknownst to us, the torch was passed. And we did it for the patients, and they made our lives so real. And we did it for the patients, to treat, to teach, to heal. We learned faith in human kindness, for to live is to believe. We learn when we serve our patients, to give is to receive.
Now we're efficient and more proficient.
But that human touch has turned to frost.
High-tech seductive, we're more productive.
Something's gained, but there is something lost.
What's the cost?
We love medicine so pure, love the pill that brought a cure, love the magic of a surgeon's knife. Love the music of the wards, in our patients we heard chords, and we felt we were in tune with life. Now we're robotic, care's idiotic, no time to call a patient by her name.
It isn't funny, we're losing money, because medicine's a brand new game.
Not the same. And we did it for the patients, took an oath to ease their pain. And we did it for the patients, and not for our own gain. Since then 40 years have passed, our ideals didn't last. We went different ways, sought different goals. Patient care is where it's at.
I can earn much more than that.
In these times, what is a doctor's role? Do we follow or need?
Or get what we need.
Can we find our heart and soul?
These are critical times.
Yep, these are times of crisis.
Greg, you know, in Chinese, the word for crisis has two symbols.
One symbol stands for danger.
And the other symbol stands for opportunity.
In healthcare today, I see lots of danger.
I see lots of opportunity.
Opportunity? What opportunity? Seems to me there's less and less opportunity for people to get decent medical care.
Greg, it seems to me that there's more and more opportunity for growth and for investment.
Growth and investment? In what?
Healthcare business.
Healthcare business?
Yes, Greg, get with the program. This isn't the 20th century anymore.
What are you talking
Have
about?
a seat. Here's the prospectus. Just follow along with me. Healthcare business ain't fair business. We gain when care's denied. Needless urgent care we have been scorning. Care without approval's a mistake. Take 2 aspirins, call me in the morning.
The less we do now, the more we make.
Now you got it nowadays. Surgery needs pay. Surgery is quickness. Makes us so rich. No more second opinions, you don't need to wait. For double hernias, we cut the rate. The rapid service in by 7, out by 8. Our OR time surely shrank.
But we're spending more time at the bank.
A grand business is scan business. All patients need MRIs. Computed scans improve disease detection. X-ray pictures now seem pretty crude. Scans improve our financial projection.
And give protection if we get sued.
Thank goodness it's choose business or lose business. The choice is very clear. Put your money down, you really can't be screwed.
Why go bankrupt? You can be shrewd.
You wouldn't want to practice on the street for food. To be a doctor today, healthcare business is clearly the way. Hey!
Barry, can you get up, please?
Just a second.
Thank you. Whew. Glad we eliminated the back flip from that routine.
Yeah, me too. Business of medicine, more and more the way of the future.
I'm not so sure about all of this.
Add to that computers. Imagine what practicing medicine will be like.
Yeah, but what about our focus on the patients?
All the journals will be on the internet.
Have you tried accessing that stuff?
Every patient's outcome will be monitored.
Monitored? By who?
Every person will have a little chip inserted at birth, and they'll make reimbursement instantaneous.
Who's going to pay for that?
And the role of the physician will be changed.
Changed? Changed how?
Oh, lots of different ways, like writing prescriptions over the internet.
But Barry, what about the doctor-patient relationship?
Been there, done that. I do drug sales with my emails. I can treat anyone who is sick, males or females. All I have to do is point and click.
No relations to your patients, so you don't use your stethoscope much. Separation, so you never have to feel or touch.
No more physicals done directly.
Keep your hands clean.
Never have to move from my screen.
Glued to his screen.
No more quelling fears.
No more shedding tears.
No more quelling fears, so my hands stay clean. We're so giddy. Profit's pretty. And we don't have to be face to face. Found our place. We are doctors in cyberspace.
Barry, I am a doctor, not a computer operator.
I'm a doctor too, but I keep up with technology.
Yeah, you keep up with technology, but you've lost touch.
Lost touch. Look, I'm on Facebook, I'm on LinkedIn, and I tweet.
Tweet? I still practice medicine the old-fashioned way. I still listen to what a patient has to say. Don't care about emails or faxes and such, 'cause medicine is all about the human touch. I still practice medicine like a work of art. You deal from your head, but I heal from my heart. Don't care if your health coverage doesn't cover much, 'cause medicine is all about the human touch. Feel the pulse with each and every beat, the rhythm of life. Feel it in your feet, feel it in your body, feel it in your soul. The rhythm of life will make you more whole. I still practice medicine at a patient pace. I still practice hand to hand and face to face. You're sending emails through the skies, while I'm on earth with my ears and eyes. Using your computer, you won't feel much. It's just a crutch. Yeah, medicine is all about the human touch.
The human touch, the Midas touch. The business of medicine. Medicine.com. Look at this.
Medicine.com. Oh, wonderful. Websites to make money from human suffering.
No, Greg, you got it all wrong. The business of medicine, diagnosis, treatment, and prevention.
Prevention? You're into prevention?
I'm into prevention with screening tests.
Oh, wait a minute. That's not prevention.
Don't you remember from medical school, Greg? Screening tests are secondary prevention.
No, all right, wise guy. So what's primary prevention?
A primary prevention would be something like getting all the soda machines out of the high schools. That would be primary prevention.
Oh, yeah, we should be doing primary prevention.
Greg, you don't understand. Look, follow along with me, okay? Got all the soda machines out of the high schools. Then the soda companies would be making less money, right?
Right.
Okay. Soda companies are making less money. They'd be paying less to the government in taxes, right?
Right.
And they're paying less to the government in taxes. Then the government would have less money to get the soda machines out of the high schools.
Right. We better stick with secondary prevention.
Secondary prevention, screening tests for all you wonderful people. The new Chem 1000 profile has just been released. 1,000 tests free of charge.
Free of charge?
Of course, Greg, free of charge. We'll make up the cost of the test later, several times over. You'll see.
Oh, wait a minute. I do see. See, if he does enough free screening tests, eventually everybody's going to have something abnormal. Then you're going to need non-invasive diagnostic tests. And then you're going to need invasive diagnostic tests. And then you're going to need treatments.
Not for free. Have a test. Have a test. Heed our simple free request. Drawing blood just takes a moment, so sit back and sing along.
Have a test, have a test. You don't have to get undressed. No one's health is perfect anymore, and we'll find out what's wrong. Have a test, have a test. We detect disease the best. We call it check-in, check-up, and check-out. So put your life in order. Come and pass some water and be blessed. Have a test, have a test. Give a try. Don't ask why. A comprehensive MRI. We will image every body part. We'll see if they look well. Don't be fools. Give some stools. We will check the molecules. Have a total body biopsy. We'll check out every cell. Have a test. Have a test. You will be so much impressed. You'll only need to step inside our door. You'll feel a lot more healthy. We'll be lots more wealthy. Be our guest. Have a test. Have a test. Yes, ladies and gentlemen, it's the check-in, check-up, check-out home test for mad cow disease. You simply drill a small hole in the skull, suck out a little brain, put it in this tube, and it turns blue. And please, don't forget our do-it-yourself colonoscopy kit. So, ladies and gentlemen, please remember, have a test, have a test. You will be so much impressed. You only need to step inside our door. You'll feel a lot more healthy. We'll be lots more wealthy.
Be our guest.
Have a test. Have a test. Just have a test.
Thank you. Maestro, hold on just a moment. Maestro, we have a technical problem here. Could we have a little bit of assistance? While I was having a test, I lost my microphone.
Wow, you really did a number on that.
I love those tests.
It was like a test.
We have to go again. Hold on.
The show must go on.
We take you now to the Honors Colloquium for Microorganisms, now taking place in Narragansett Bay.
So wonderful being here with all the microorganisms, the bacteria, the viruses, even the fungi and the molds.
Hey, hi, how are you? Geez, everybody came. But you know, it's really difficult to recognize each other without a microscope.
Yeah, it sure is. Hey, how's your family doing?
Oh, I'm proud to say that the staff family is alive and well.
Alive and well. Didn't vancomycin almost wipe you all out?
Well, almost, but not quite.
I read it in the University of Rhode Island Gazette that 99.99% of your family just suddenly dropped dead.
Well, that's true, but that still left me with 10 surviving children.
10,000 surviving grandchildren, and 10 million surviving great-grandchildren. Want to see the pictures?
I just put them up on Facebook.
Oh, I now have well over 1 million trillion great-great-great-grandchildren. Want to see their pictures?
Wow, all of them resistant to vancomycin?
Yes, and resistant to just about every other antibiotic known to man.
What a time to celebrate.
We bugs have much to be grateful for.
Multiply resistant TB up in Providence.
The resurgence of the Ebola virus in West Africa.
Lyme disease down in Connecticut.
Mad cow disease all over the place.
And look, in the Wall Street Journal today.
Ooh, e-business.
No, E. coli.
Another outbreak. Another outbreak of us super bugs.
Another outbreak of super bugs. An epidemic, come on, some hugs. Another failure of wonder drugs. Another outbreak of us super bugs. Salute TB,
our resistant group. Salute the strep, they turn flesh to soup. Salute E. coli, they live in poop. Another outbreak, what a snazzy group. Go ahead, give us nice Latin names, but we will get you quite just the same. Invading your body's our number one goal. You can't cover up each and every hole. We are devising some brand new schemes. We're scaring parents about kids' vaccines. Whooping cough is now on the rise, 'cause parents don't get their kids immunized. At this stage, we travel in style, and we earn many a frequent flyer mile. Yesterday, far away, one of us grows. A jet flight today, and we're in your nose. Against us bugs, no security. So don your mask and call CDC. Wear gloves, wear condoms, use DDT. You might gram stain us, but you can't contain us or our family. Hey!
You know, Greg, we should get together sometime and talk about your entire investment portfolio.
Investment portfolio? Investment portfolio? I can't even pay my Visa bills.
Seriously, Greg, at your age, in these uncertain times, you need a balanced portfolio. Birthing centers, screening clinics, funeral parlors.
Oh, I get it. Check in, check up,
check out.
Check out.
Trademark.
All right, fine. You win. Let's do lunch sometime.
You got your calendar there?
Yeah, yes, I have a calendar.
I got my new 6G iPad right here. It's a combination web browser, fax machine, and hot plate.
Really? How's that thing on batteries?
Well, it's made in Iran, so it's nuclear powered.
What?
How about next Tuesday, December the 11th?
December the 11th? No time. I've got a downsizing committee meeting then. Hey, how about Wednesday after the New Year? Wednesday, January the 9th?
No time. My hospital's having a Chapter 11 bankruptcy hearing that day. How about a Thursday, February the 29th?
February 29th. Oh, no time. I'm starting my mini residency in cosmetic surgery that day. Ooh, how about Friday? How about Friday, March the 29th?
I'm starting my Amway distributorship then. Listen, why don't I send you an email message with my available dates for the rest of the century?
Who has time for anything anymore?
I've got lots of piles of stuff to put in files.
I'm too busy with patients' needs. I can't read. No time. Time just to be employed. No time to be enjoyed.
What do I hear from the kids and wife? Get a life.
Get a life. No time. No time. Life's supposed to be lots of giving, but my life's just earning a living. No time.
A chocolate bar and fries. No lunch, no exercise.
There's no time left to heal myself. No time left to reveal myself. No time, no time. maybe then we'll be inspired to take time. Time, please wait for us.
Time, please be late for us.
Lots more things that we want to be with our friends and family. No time, no time, no
Time.
Greg, I just got some stimulus money from the federal government. I'm starting up a new business. It's called Modular Medicine. Modular medicine.
Modular
medicine.
Modular medicine? What the heck is modular medicine?
How can I explain it to somebody like you, Greg? What do you do when your computer breaks down? I mean, you call in a repairman these days?
Well, no, that's much too expensive. I mean, these days you take out the old part, throw it away, go on the internet, you order a new part, shows up in the mail, you plug it in, you're up and flying again.
Same concept with human beings.
Well, you're talking about transplants.
Yep, I am. That's what I'm talking about.
Well, it's always been a lovely concept, but what are you going to do about the donor problem?
I'm glad you asked. You see, I'm in the startup phase of this new business. I'm cloning pigs in my garage.
Cloning pigs in your garage?
And I'm selling the organs on eBay.
Selling the organs on eBay? Barry, have you considered the ethical implications of that?
Greg, ethical, schmethical. Have you considered the investment opportunities?
Investment opportunities? Oh, wonderful. I can just see this. 200-year-old baby boomers wandering around huge shopping malls searching for spare parts. Got myself a kidney and adrenal gland.
Next week I'm getting someone else's hand.
Got a brand new ticker.
Now my hair is thicker.
Got myself new legs, but don't know where I stand. A new man's in my shoes. Got the spare parts blues. Got myself new eardrums, everything sounds strange.
Got myself new gonads, but my sex didn't change.
Got a llama's liver.
Makes you want to shiver.
Got a new persona.
1-for-1 exchange.
Brand new skin.
Don't know whose.
Got the spare parts blues. Spare parts, spare parts. It's getting so no doctor can repair parts. Spare parts, rare parts.
It's getting so with animals we share parts.
Got myself new muscles that I can't maintain.
Got myself new nerves and someone else's pain.
Now and then I sicken, cause my stomach's chicken.
Got eyes of an eagle, but a turkey's brain.
Who am I? Got no clues. Got the spare parts, spare parts, spare parts blues. Yeah! So Barry, there is something I just do not understand here. I mean, here you are talking about everything getting bigger and bigger, but how are you going to control the cost of all of this?
I can tell you that in a single word. Downsizing. Downsizing.
Downsizing.
Figure number one.
No, I get it. Fewer doctors.
Fewer doctors, but looked at in a slightly different way, a lot more efficiency from each of the few remaining doctors.
Right, and fewer clinics.
Fewer clinics, but then again, looked at in a slightly different way. Actually, yeah, fewer clinics, but looked at in a slightly different way, a lot more proficiency from each of the fewer remaining clinics.
Right, and of course all of this leads to lower costs.
Lower costs, but higher stock prices.
Higher stock prices. I should have guessed.
We have
cut every needless expense, all that cures, everything that prevents, we have cut. Using good common sense, that's cost containment. Tell patients that they've overstayed. Tell the docs that they cannot be paid. Fire 3 nurses, hire an aide. That's cost containment. The day of decision will soon arrive. Yeah.
Yes, we're concerned that our patients survive, but first our hospital must stay alive by replacing health maintenance with good cost containment. Close the lab, close the visitors, John, don't go mad. Halls, the shrinks have moved on, have a Coke. The cafeteria is gone. That's cost containment.
Medicare's not been cut, its rate of rise is decreased.
Medicaid's not been cut, it is only deceased. Who needs a doctor? Go out, get a priest. It's economizing and everyone's downsizing. You may think that you need a nurse. There are no nurses left. Get a hearse. You may think that the system's perverse.
Worse.
Healthcare's in reverse, but we're reimbursed. That's cost containment.
Oh, Greg, you know, the logical extension of all this cost containment is the end of the medical profession.
Huh. You mean no more doctors?
I mean no more doctors. What do you think I mean?
Well, that's certainly possible with the way things are going.
We'll need doctors with the efficiencies of managed care.
Yeah, computers replacing everything we do.
I heard in Washington that they're starting to pay patients not to see doctors.
Really?
It's called medical savings accounts.
Oh, right. Hey, you know, even scarier yet, dogs may be replacing doctors for the few remaining things we are needed to do.
Dogs? Did you say dogs?
Yes, Barry. Check out this entry in the class notes section of our medical school's alumni magazine.
When do you attempt to read that
No,
silly
no,
stuff?
Barry, listen to this. Bob Martin, senior member of an oncology group in Hartford, has 5 kids, 2 grandchildren, wife, and a dog who makes rounds with him at the hospital. A very full life indeed. As for this dog, a press piece from the hospital explains that her name is Abby, and her visits have been extremely well received by patients and staff due to her extraordinary innate sense of how to react to people, especially children, who are not feeling well. The hospital is considering a hospital-wide program of pet therapy.
Pet therapy?
Right. No need for doctors anymore. Are we a pair? Best team around. Me very high in the air, you on the ground. Send in the dogs. Smell wine on breath. Hear high-pitched heart sounds. Able to sniff out the cause of every disease on patient rounds. Just send in the dogs. Make sure there are no fleas. And now I wait. Open your door. Await the sound of your bark, the step of your paw, making your entrance seem much more important than mine. I've not complained. You've got me trained. You're just a dog. You're just my pet. I, in my dreams, never thought you'd be a threat. You'd feel my heart throb, your small fur slob. You've taken my job. So, Barry, there's something else I do not understand here. I don't understand how your hospital can be doing so well when our hospital is going in the toilet.
Yeah, it's time to listen to my lecture series.
Lecture series. You have a lecture series.
I have a lecture series. It's called PowerPoints to Profit, Transforming Your Patient Mix.
Transforming your patient mix?
Yeah, it's now out on CD, interactive DVD, downloadable MP3, and, of course, Blu-ray. Here, have a listen.
Barry, I can't even open the shrink wrap on these things. Can you summarize this for me?
Sure, I'll summarize it for you. Lecture number 1, only sell to the worried well.
only sell to the worried well.
Right. Lecture number 2, how to avoid the unemployed.
Avoid the unemployed?
And most importantly, lecture number 3, do not pick the sick.
Do not pick the sick. Barry, what about the community hospital's responsibility to the community?
Greg, there's money to be made. Smart hospitals succeed by not admitting people who are poor or who may bleed. You only need to say these 4 words quick. Go away, you're sick.
Oh, look, here comes an ambulance. Admit him, he's in shock.
I think he smells like beer.
Admit him.
Better not, the city hospital is near.
I think he has a hemorrhage, treat him quick.
Go away, you're sick.
Hey,
Greg, it's clear that things will worsen unless we're in the black. We don't treat an ailing person till we get our money back.
oh, look, this one's for psych. She hears voices in her head.
I think she is a fake.
I think she's schizophrenic.
No, I think that's a mistake.
Admit her to the ward, her wrists have cuts.
Go away, you're nuts. Greg, the way you think's outmoded. Treat the well, not those near dead. All your bills should be recoded.
Or we'll end up in the red.
Well said.
So a surplus can be made.
Patients buy what we can sell.
So if you are on welfare,
We don't care, we say farewell.
all hospitals must learn this little trick.
Do not pick
The sick.
That's right.
To this mantra we must always stick. Go away.
You're sick.
You're sick.
You're sick.
You're sick. Now go away. You're sick.
Ladies and gentlemen, we take you now to a meeting of the ultimate gatekeepers, now taking place in Hartford, Connecticut, the heart of the insurance industry.
This is terrible. This is unspeakable.
What's so terrible? What's so unspeakable?
Oh, it's Obamacare. Obamacare. Obamacare is now the law of the land.
It is the law of the land.
Well, it's getting more and more difficult to make a profit out of this. We have to cover those kids until they're 26. We have to cover pre-existing conditions. And worst of all, we cannot kick people off their policies when they're sick.
Oh, terrible. What are we going to do?
I don't know. Oh, shut up. I must think. The plan. Yeah. Ooh, wait. I've got it. I have got it.
What do you got?
This is a policy which appears to cover everything.
Oh, perfect. Take a close look at it here. But actually, it seems to cover nothing.
Precisely. It's the perfect policy for Obamacare.
Ah, wonderful. We do not cover oral health or anything that's dental.
We do not cover psychic health or anything that's mental.
We do not cover eyeballs even if you're going blind, cause everything that's in your head's just in your mind.
We will fight, protect patients' rights. We're only here to please. Just don't get sick. You'll find out real quick. We don't cover your disease. Look at this. Rider Q.
Wonderful. Our reproductive benefits have frightening descriptions.
We'll tell you try Viagra, but we won't pay for prescriptions.
For women, yes, we do support your legal right to choose, except there isn't any doc that you can choose.
We will fight, protect patients' rights. We're only here to please. Just don't get sick. You'll find out real quick. We don't cover your disease.
Tambourines. We do not cover pre-existing diagnosed conditions.
We do not cover future risks that might come to fruition. We do not cover chief complaints, no matter big or small. We do not cover anything, no, not at all. We will fight, protect patients' rights. We're only here to please. Just don't get sick. You'll find out real quick.
We don't cover your, we don't cover your, we don't cover your disease. Hey!
Look at this, Greg. A healthcare policy that covers absolutely nothing. What a wonderful way to make money.
Money? Money again? Barry, I just don't understand what's happened to you. I mean, when we were in medical school, we used to go to third world countries and work in hill clinics. Now you're wearing an Armani suit and smoking a Cuban cigar.
Greg, I don't know what happened to you. In medical school, you were voted most optimistic in the class, and now you're negative. Negative, negative, negative.
Negative? Me negative?
He's negative.
I'm just trying to figure out how somebody like you, who is so committed to public health, ends up as this money-grubbing entrepreneur.
Look, when the politicians started taking over public health, I just got fed up. I said, screw this. I'm going into business for myself. Now, when I make money, everybody wins. You, Greg, what happened to you?
Well, you know, I mean, after practicing clinical medicine for 40 years, I just burned out. I mean, I was fighting with the hospitals. I was fighting with my colleagues. I was fighting with the insurance companies. I was fighting with my patients. I was fighting with my wife. I was fighting with my kids. I was fighting with everybody. I'm on strike. I'm in debt. I mean, I'm running as fast as I can to stay where I am, and I'm falling behind. I'm going under here. I don't even know why we went into medicine in the first place. Hey, why did we go into medicine in the first place?
Well, for me, that's an easy one. You see, when my Uncle Lou, who's a family practitioner, when he delivered me, he turned to my mother. Instead of saying, it's a boy, he said, it's a doctor. So from day one, it was sort of, predetermined. I actually grew up with that story. And when I was a teenager, I got to see, well, this is kind of a story. Being a doctor's not so bad after all. I mean, steady income, intellectual stimulation, and you could not only cure people, but you could prevent them from getting sick in the first place. You, Greg, why did you become a doctor?
Well, that's something I haven't thought about in a long time. But I was remembering the other day when I was a little kid, about 7 years old, out of the blue one night I had this asthma attack. I mean, it scared the living daylights out of me. My parents stuck me in the bathroom, and they're running this hot water in the bathtub, and this steam is bubbling up, and it's filling the room, and I'm sitting on the toilet, and I'm screaming, I can't breathe, please help me, I don't want to die. So my parents called our family doctor. This guy came, and he made a house call. He gave me a shot of adrenaline, but then he sat there, and he held my hand, and he told me these stories until my breathing started getting easier, and I started feeling better. And as I was going through school, I kept thinking about this guy, and I kept thinking, it wasn't so much that shot of adrenaline as it was him telling me those stories and holding my hand.
The human touch is so important. I chose to be a doctor of medicine, to live a life in which I could excel, to serve the public with preventive medicine, to help keep people well.
I chose to be a doctor of medicine, to live a life with a loftier ideal, to serve my patients, practicing good medicine, to treat, to teach, to heal.
Then you got burnt out, work became just a grind.
You started a business, got lost.
You couldn't keep up, progress left you behind.
You became rich, but you didn't see the cost. Still we can feel the magic of medicine, a mystery like forces from above. Still we can hear the music of medicine,
A symphony of love.
How can I contact the Greg I once knew?
Can I look myself in the eye?
Can I find the meaning in all that I do?
Is my life just a lie?
Who are you? Who am I? We'll always be two doctors of medicine, no matter what, no matter where or when. We've sworn an oath, we pledge our lives to medicine. Two doctors of medicine in harmony
again. Well, Greg, Greg. We sure covered a lot of problems this evening.
Well, change brings with it problems, but also opportunities. Didn't you just say that a little while ago?
I did say that.
Well, somebody's got to be responsible for this mess that we're all in.
Who do you suppose that could be?
You and me.
Me and you.
Yeah, us and them.
Them and us.
Yeah, us and them. All of us together are at least partially responsible for this mess we're all in.
All of us together.
And if we all help to create these problems, maybe we can all help do something to solve them.
Good point. If we want to shape the change, let's go and see what people need and listen to our inner voice, and then as leaders take the lead.
When there is love that fills our heart, when there is spirit in our soul, then together we can heal the world, make it whole.
Change is not a passing fashion.
Must be nurtured, must be planned.
Must be carried out with passion.
Needs our heart and needs our hand. For good patient care and a system that's fair, take a stand.
If we want to shape the change, let's go and see what people need and listen to our inner voice, and then as leaders take the lead.
When there's love that fills our heart, when there is spirit in our soul, then together we can heal the world, make it whole.
With each word that speaks our mission,
with each action that we take,
we'll embrace change with our vision.
See the difference that we make.
The health of the nation, the next generation's at stake. If we want to shape the change, let's go and see what people need and listen to our inner voice, and then as leaders take the lead. When there's love that fills our heart, when there's spirit in our soul, then together we can heal the world, make it whole. Our heart and soul.
Damage Care, Dr. Barry Levy and Dr. Greg LaGana.
Brad Ross on the keyboard. Brad Ross. So we're going to now have a question and answer period. Thank you very much.
Thank you very much.
Thank you. So we have some questions. I'm not sure if we'll have the answers. Just because we do the show doesn't mean we're experts.
We turn this
on all
over
the
to
questions that
the
make
Q&A
them up,
people.
but, we'll give it a shot.
I feel like we're in one of the debates. We have 2 minutes to answer. Get a
we will
teleprompter and
not
everything.
attack each other. We'll try not to.
I beg your pardon.
Okay, and we have, okay, good. We have a little teleprompter here. What questions do you have for Damage Care?
So as actors, you poke fun or make light of issues of healthcare. As doctors, these issues are what you must see at work day in and day out. Are there any immediate solutions to the problems that you point out in the play?
Yeah, you take that one.
All right, one-word answer to that, no immediate solutions to the problems. You know, in point of fact, if you think about it, we're talking about a huge endeavor here. I mean, you know, healthcare in this country is 1/7 of the economy. I mean, it's bigger than the gross domestic product of a lot of other countries. I mean, so as a very wise man who was the chairman of the board of a hospital that I worked in New Jersey once said, when you're trying to turn something the size of the Queen Mary, it takes 17 nautical miles before the rudder even begins to bite. So there are solutions that are being proposed. Everybody kind of is jumping up and down about Obamacare and, oh my God, the mandate and the this and the that and all the rest of that. But they also know it's 2,000 pages, and what's in those 2,000 pages is a lot of experiments. It's a lot of experiments to try to change the fundamental way that we deliver healthcare in this country. And they're being tried out. Accountable care organizations, health information exchanges, electronic medical records endeavors, all of that, patient-centered medical homes initiatives, all of those things have to be tried out, and we'll see which ones work and which ones don't, and try to make it better. But you know, it's a real good question. Barry?
And Greg spent a lot of his career in internal medicine and occupational medicine. I've spent much of my career in occupational medicine and public health, and some emergency medicine. Greg did
did a great deal of. There's no easy one answer, and I highly recommend a speech given by Harvey Feinberg, former provost of Harvard University, former dean at the Harvard School of Public Health, and former president of the Institute of Medicine. He gave a talk called the Shattuck Lecture earlier this year. It was published in the New England Journal of Medicine, and it talks about all the things that need to be done. And the bottom line of what he says is that, yes, we need new ways of paying doctors, we need more prevention, we need the kinds of experiments that Greg was just talking about. We need all of those things, all those good ideas, and we still, over and above that, need a new way of thinking. So there's no one magic bullet, there's no one magic answer. We need everyone's ideas, and in fact, the message from our show, I think, hopefully, is get engaged. Do whatever you can. All of us have a role to play. We live in a democratic society. I'm going to ask the moderator to go on to the next question, please.
Yes. Can you tell us your most interesting story that relates to the issues of healthcare?
Wow. You want to take that?
My most interesting story that relates to the issues of healthcare. All right, so I got this thing. A large part of my career was working in a community hospital in central New Jersey. It was called Muhlenberg Hospital. And the interesting thing about that community was that it had been known for a very long time, over 100 years, as the Queen City. It was a place where wealthy Wall Streeters had second homes, and the hospital was considered to be the hospital of the Queen City. So the medical staff, which had for a long time all power in that hospital, was dynastic. There were fathers and sons and grandsons and like that who were on the medical staff. In 1967, there was a race riot that started in the streets of Plainfield, which was the sort of equivalent of a small nuclear device going off in the middle of the town. All of the wealthy people vacated to the sort of the edge of the blast crater, to all of the communities surrounding. Muhlenberg Hospital suddenly became the hospital, the municipal hospital of the people, who actually were minorities who had worked for the wealthy people in their home. The demographics completely changed over. There was a section of Plainfield which was known as Sleepy Hollow, which always struck me as ironic because that's where all of the old board members lived. And the old board members would get together periodically to talk about how they could entice all of the rich people to come down from the hills and repopulate Plainfield. And that the key to that was yours truly, who was running the emergency room, to get all of those scary people to go to the community health center, which was downtown, like that. And that eventually evolved into a serious conversation about the survival of that hospital, because there was a great deal of uncompensated care going on there, and the hospital started hemorrhaging money. The director of the hospital, when I got there, was a guy with a vision who really wanted to run it as if it was a small Johns Hopkins. And he had forged an alliance with the medical school. He saw it as a major teaching hospital. I did my training at Harlem Hospital in New York. This was like a mini Harlem, and anybody who's done work in a municipal hospital knows you will see really sick people there. And if you learn how to take care of them well, you can take care of anything. So Muhlenberg had that kind of role in the training, for the medical school. So there were residencies. And as the money began to hemorrhage away, the residencies began to fall like that. And as the residencies began to fall, the hospital became less and less lucrative. And it eventually was picked up by another community hospital in a so-called merger, and eventually just died of uncompensated care. And that was because people, as he said, couldn't come up with a new way of thinking about the problem. They thought that what they needed to do was just to figure out how to get all the rich people to come back down into Plainfield and everything would be fine. And you can't do that. That's not where it's at.
The story that comes to mind for me is as a medical student, and Greg spent some time there as well, quite a bit of time on the islands of Jamaica in the Caribbean. And the very first day I was in the clinic there, fourth-year medical students.
We really did go to third world countries and work in hill clinics.
Right. And the very first day we were there as fourth-year medical students, Dr. Alderman, who was our faculty member, I had just seen a 7-month-old boy with a respiratory infection. He had cough and fever and junky lungs. When we listened to him, you could hear the rattles in his chest and so forth. And Dr. Alderman came in and said, Barry, what's the diagnosis? And I said, upper respiratory infection. And he said, wrong. And I was dumbfounded, and he said, the correct diagnosis is malnutrition. And we had all been trained at New York Hospital and related clinics in the east side of New York and Queens and so forth, and we never saw malnutrition to the degree that was occurring in Jamaica. But even with a degree of malnutrition, we missed it because we were so focused in on infectious diseases. And that one encounter is a metaphor for me for so many other encounters where social determinants of health, and I know this is a big movement now in public health and medical care, but in appreciating the social determinants of health, which go far beyond personal choices such as smoking and the foods we eat, but the social determinants, nutrition, which is in part based on the availability of healthful food and so forth, and many other social determinants, poverty and so forth. But that's the encounter that comes to mind to me. Next question. Oh, thank you.
So the New York Times published a story today about Superstorm Sandy induced temporary closure of several urban hospitals in New York City and the subsequent rise in ED visits and income in surrounding operational hospitals. What are your thoughts about competition in municipal hospitals in this situation in New York City or elsewhere?
Wow. Why don't you start again? I'll think about that one.
Well, so when I was at Muhlenberg, I went there initially as a medical educator. I was a teacher, which I had a great deal of enjoyment doing. And then the hospital decided to have a major reorganization. That's where I heard that guy about the 17 nautical miles for the rudder to bite. And when the dust settled on that, I was the chief of ambulatory and emergency medicine at this hospital. And we were implementing at that time mobile intensive care. Well, let me tell you that the competition between us and the surrounding hospitals was like a feudal war. I mean, it was unbelievable. I mean, in terms of like drawing boundaries. I mean, you talk about gerrymandering, for God's sakes. I mean, it was. I used to come home and tell my wife stories about this, and she'd just shake her head. So, that was a new way of thinking for hospitals. That was kind of like a wrong way of thinking. People started worrying about their market share, and so on and so forth. I mean, not to digress too far off the way here, but I mean, if you think about Obamacare, one of the major criticisms about Obamacare is, okay, fine, they addressed the accessibility problem. There'll be whatever the number is, pick your number, 30 million more people, with availability of health insurance, presumably. But they really haven't truly addressed the cost issue, our little kind of curves, going up and down, bending the cost curve and all the rest of that. And so hospitals, were always looking for a way to increase their revenue streams. And the state of New Jersey was always trying to figure out a way to control the cost. So they would come up with all of these schemes, certificates of need and all the rest of that. And the hospital administrators would just turn around to medical staff and basically say, if we build you a cardiac cath lab, will you use it? Do we need one? And they say, absolutely. Why? Because we're all making a hell of a living off of that horse. So I mean, and so you look at the growth of the cost curve in the United States from for the last 50 years, 1960 up until 2010, it's an exponential growth curve. Looks like a compound interest curve. And that basically means there's a positive feedback loop. There it is, that's why we did that. It's the other way around, actually. It's sort of, it's backwards, okay, but if it was growing this way, that's the way it would grow. Go here, like that. There you go. We got it right, figured out like that. And that just basically means, there's a positive feedback loop operating in there. I mean, so, yes, I mean, competition between municipal hospitals is part, I think, of the problem, basically. And here's another thought, and I'll let Barry say something. I probably should be fact-checked on this because I heard this sometime in the last several months. This country, the United States, is the only country with a healthcare system that is fundamentally thought of as a business proposition. We think of it all in business terms. And if you think of it in business terms, I mean, what is the major purpose of a business? It's to generate profits for its shareholders. Oh, higher stock prices, of course, And that it's not in business to employ people primarily, And the primarily, it's not in, presumably it's in business to provide a good or a service which will help generate its revenue, but, they're sort of sitting there and saying, okay, well, fine, let's go out and figure out what goods and services we can convince the community it really needs, and get it before the hospital over there does the same thing.
Yeah, I don't have that much to add, and I agree with a lot of what Greg said. I think we always need to keep in mind that municipal public hospitals have traditionally been on the short end of the stick, so to speak, not being adequately funded, their emergency departments flooded with, and that's not the right word, but filled with people who at least up to now have not had health insurance, at least not adequate health insurance. So I don't have anything further to add than that, so let's move on. Thanks.
How do the issues presented in damaged care relate to the nursing profession? And this is sent from a nursing student who's wondering how they can advocate for change.
Well, it's interesting. We've done several shows now, either for nurses or nursing students, and you're our best audience, really. Nurses, I think, are closer to the issues than a lot of physicians are, and certainly a lot closer to the patients and what the patient's concerns are. I think this is a question, though, that we really want to toss back to you, who are faculty members and students here and perhaps elsewhere. We shouldn't be telling you what, specifically what you should be advocating for, but we would like to empower you, if that's the right word. We encourage you to advocate from your perspective and from the patient's perspective you're closest to as to what to advocate for. Keep in mind, and I quote this often, the saying, and I'm not going to give it exactly, but the quote by Margaret Mead, who many years ago said, "Never doubt the power of a small group of individuals who are really passionate about an issue and persistent and want to see change." That's, in fact, the only thing that brings about change. So be passionate, focus your energies, get organized, and advocate from your perspective. We need to hear your voices, not we, but society and our policymakers.
Yeah, that's an interesting question about how does damaged care really address nursing? And we had a few things in there obviously that pertain, but I was thinking about it. I was having a conversation before the show with Mary Cloud, and she was telling me about some of the other presentations you've had here, Mary, and about the primary care clinic initiative in the state of Rhode Island, and there's a huge primary care vacuum, huge. So, I mean, if you think about it, although we didn't really consciously set out to create it this way, my character in the show is obviously a burned-out primary care doc. I'm on strike, I'm in debt, I'm running as fast as I can to stay where I am, and I'm going under here, like that. And so doctors are not going into primary care. This is a huge fight. I mean, I was at an American College of Physicians, state meeting in New Jersey, and it was like the political third rail to start talking about the reimbursement differential between primary care docs and the specialists. You want to start a fight, just have that conversation like that. So that vacuum has got to be filled. And Mary was basically saying nurse practitioners are going to have a huge role in that, and I agree with that. Yeah. I really do. So I mean, I think that's another kind of a take on what we're talking about here.
I fully agree with that. I mean, just think in terms of whatever that number is, but say 30 million people coming into the system in the next few years through Obamacare and related programs, nurses really have an important role to play there. Absolutely. Next question.
Great follow-up. How would you go about making the field of primary care more attractive to medical students?
Well, I think that may or may not be the right question. I'm not saying somebody's asking the wrong question, but I think the broader issue is how do we as a nation provide, as a society, ensure that primary care is accessible, that it's high quality, and it's it's affordable. And even in Massachusetts, where we have Romney Care. But in all seriousness, we have a program that Governor Romney signed into law in 2006. It's been implemented for much of the 6 years since then, and it's very difficult to find a primary care physician in Massachusetts. So I think part of it may be trying to create incentives for that, although that's been tried before, and we need some new ways of thinking about it. But I think a very important part of the answer are nurses and nurse practitioners and how we organize medical care.
Yeah, that's a difficult question. It makes me think. There was an article sometime. I wish I could find this thing. I think you may have sent it to me actually, and I believe it was in the Journal of the American Medical Association. It was by a physician, and he said, he was addressing the dissatisfaction and unhappiness of physicians in this day and age. A little bit of my character derives from that. And he made an interesting point. He said, if you listen to the conversations of doctors, offline, in the coffee shop or the locker room or whatever, they ain't talking medicine. They're talking money. Money again. And he says that started, interestingly enough, and it kind of spun my cap around. He says that started when Medicaid and Medicare came in, primarily Medicare. All of a sudden, physicians started worrying more about their reimbursement rates. I mean, honestly, we can have all kinds of conversations about the deals that were cut to get Obamacare in place. But do you know that the only thing that I heard coming out of the AMA was that every year they want to do something about the Medicare sustainable growth rate, which is don't go cutting my reimbursement, dude, like that. I mean, really, and doctors are not happy. They're not happy. So somehow or other, there's got to be a re-embracing of his speech, about the intellectual challenges and satisfactions of medicine. You sent me that interesting article about that guy. Was that in the Times? Probably. Yeah, in the last couple of days, there is this guy. He's like the real life Dr. House. He will, he'll just go there. They'll present him with a cold case that nobody's been able to diagnose, and he just kind of sits there and he just kind of like runs it through. And he says, I do this deliberately to basically show people the pleasures of thinking. I mean, so here's another funny story. I was at a Christmas party at this hospital, Muhlenberg, one year, and I was going around, making nice to all the other departments, and I had a medical student in tow with me who was on the medical rotation. So we stopped into the surgical, recovery room in OR, and there was an anesthesiologist there, and he knew the medical student because he had been on surgery the months before. And he says, so what rotation are you on now? And he basically goes, internal medicine. He goes, internal medicine, the thinking doctors. Which made me smile. Yes. But there's something to be said for that. I don't know whether that would make it more attractive to medical students. It's certainly attractive to me, I'll tell you that.
Next question, please.
All right, from the audience, if you could affect one major change in healthcare, what would it be?
Well, I don't think. I think we need to get, and again, this is with deep respect for all of you who are asking questions, but I think we need to be thinking in terms of a broader perspective. I don't think there's one change that's going to. I think a number of different things have to happen, and some of them are probably things that we haven't even thought of before. I think it's something that Greg earlier referred to, and it's part of what's in so-called Obamacare, and that is that there needs to be a lot more experimentation. I don't mean taking advantage of patients, but I mean trying different things, probably at the local and in fact at the state level, because a lot of things are tried out at the state level. Some of them succeed, some of them don't succeed, but that's how a lot of national policies. I mean, with all due respect to Governor Romney, who signed this into law in Massachusetts, that really served as a plan for what we now call Obamacare, the Affordable Care Act. I mean, and so it was tried out at the state level. It worked. It worked beyond expectation in some ways, and then it was enacted at the national level. So I think we need to have an open mind about things. I think we have to be much more open about new ways of doing things and recognize that it's for the good of the patients, it's good of society to try out new ways.
Yeah, I tend to agree. I mean, it certainly is such a multifactorial problem. There was anybody know Frontline, PBS investigative series? They sometime in the last couple of years, there was a program that I found very fascinating. It was called Sick Around the World. And it was a journalist. He actually wrote a book that was an expanded version of this. But what he did was he went around to other developed countries that had healthcare systems. Now, I mean, if you think of healthcare as a business, which apparently we do in this country, I mean, any serious executive would fire the whole lot of them. I mean, we spend almost twice as much per capita, you know, in this country on healthcare, and we get crappy results. You know, he can give you the rundown.
16, you know this. I think many of you. 16% of the GDP in this country is on healthcare versus 8% in Canada.
Yeah.
They have longer life expectancy.
Now, the interesting thing is that each of the countries he went to, and he went to a bunch. You know, he went to England, he went to Japan, he went to Switzerland, he went to Taiwan. He went, you know, all had different variations. You know, from sort of like, you know, full socialized to some public-private partnerships. I think Taiwan did an interesting thing. They went around, they tried to take the best of everything and glom it together and make a system out of that. But the one thing that struck me was the government had a major role in every one of those systems in regulating the costs of the thing, you know? So, you know, if we could do that here, sure, that's a major change that I would like to see. Now, what is the likelihood that that's going to happen in this country? Probably pretty small, you know? I mean, really. You know, I don't mean to be pessimistic about it, but the flip side of that is, anybody know Atul Gawande's work? You know Atul Gawande? Atul Gawande is a surgeon, Harvard surgeon. He writes extensively for New Yorker, and he writes on all of these issues. He's really worth reading.
It's Gawande.
Yeah. And he, some years ago, as Obamacare was starting to be discussed, he had an article in New Yorker which was essentially, what should Obama do? You know, like that. What should this look like? And he makes the point, he says, you know, all of the countries that have their healthcare systems didn't, you know, take one that existed and trash it and then try to build a new one from scratch. They started with what they had, and then they built on that, and they made it better. And each one sort of has a flavor of the individual country that it came out of. So he's saying we need to figure out how to do that here. Okay, we like business in this country. It's not like we should just totally do away with the whole business concept in healthcare, and you know, and like my character sings in The Human Touch. Don't care if your health coverage doesn't cover much. Really? Okay. I'm sorry, I'm not a priest. You know, didn't take a vow of poverty. So we need to be starting to think about that, and people are, you know, there is serious thinking going on about that. Michael Porter, you all know Michael Porter. Michael Porter is another guy. He is the serious guy about bending the healthcare cost curve. He's written in New England Journal, JAMA, and the Harvard Business Review. Also, he's a little wonky, but he's worth looking at. So, like that.
Let me just go out on a limb. If you really press me, one change, it would be creation of a single-payer healthcare system, in effect, Medicare for all.
Oh, out of the closet. Hey, dude.
Out of the closet. Next question, please. Thank you.
All right. Last question. What evidence do you have of the erosion of the relationship between doctors and their patients, and what do you feel is the cause of this erosion?
Well, I think a lot of it has to do with financial issues. My own internist she's an excellent internist. She's been my personal doctor and my wife's personal doctor for 10, 12 years. She sees about 30 patients a day, 5 days a week. And when I'm with her, I feel like I have her full attention, and she's a remarkable person to be able to do that. I don't think every physician is able to do that, to see 30 patients a day who have a wide variety of different concerns, every one of them thinking that you know, the physician is there to assist them, and my physician is extraordinary in that respect. But she does it, you know, kind of swimming against the stream. I think there are very strong financial reasons why physicians have less time with patients, and you know, it becomes intergenerational, because the medical students nowadays and the residents, they're seeing the system that, you know, physicians 10 or 20 years ahead of them are practicing. They're seeing as their role models physicians who are constrained by how much time they can spend with a patient and so forth. Hopefully they're learning to become like my primary care physician, but I think it's very, very difficult to do that, and I think that's probably one of the main reasons that there's erosion of the doctor-patient relationship. Right?
Yeah, I would agree with that. I mean, you know, the song "No Time" in the show, I've had doctors come up to me afterwards and said they wept during that song. Among other things, when I got involved in emergency medicine, I got very involved. I was one of the first emergency physician directors of a hospital to plan a freestanding emergency clinic in the state of New Jersey. It's a little weird to think of that now. And eventually got into doing that. We used to have a scene in the show where we got into a conversation where Barry would ask me, well, are you participating in one of those discounted fee-for-service systems? And I would say, well, yes, you know, I mean, because that's pretty much what managed care
Greg,
is.
the way to succeed in a discounted fee-for-service system is you get a grant and you take all the money and you see nobody at all.
No, that's the other way around.
Oh, okay.
Okay. It's basically you see everybody, you know, you don't accept any payment, and you basically apply for charitable grants, you know. And then the other model, of course, is capitation, and that's the one where you basically see, you take all the money, you don't see anybody, you know, and you take the money.
System.
Yeah, ways of gaming the system. But the problem is with discounted fee for service, which is the major model right now, it erodes the time that the doctor has to spend with the patient, and that's where it goes. I mean, my partner and I used to kid around about having perfected the art of the 7-minute patient encounter in a freestanding emergency clinic. Hi, how are you? How's the kids? How's the soccer game going? Okay, what's the
meanwhile,
matter?
you're doing a physical
Yeah,
examination.
like that. Feeling like, okay, I've already written the prescriptions because I know that the kid has.
You're listening to the patient while you're listening to the chest.
You know, I really do think it's the time thing, and you know, most physicians will basically feel very much like they're running as fast as they can to stay where they are, and so I think the time issue would be my answer to that.
Right. By the way, my son is a cardiac nurse on the West Coast. So we have Maestro.
Damage care. We love issues on your plate. Damage care. Do your part, it's not too late. Now our musical is over. There's a lot of work to do for our healthcare to improve. It all depends on me and you. If we work together, then we can repair damage care.
Thank you. Thank you for your questions. Two last things. Thank you very much. Two last things. We're selling DVDs for $10 each if anyone would like some. We have a limited number. And we'd love to bring damage care to other associations, medical care facilities, other educational institutions that some of you may be involved with. Thank you and good night.